Good morning, everyone, and welcome. Thank you for joining us today. We're celebrating the 20th anniversary of the Diabetes Fair here at the Cleveland Clinic. I'm co-hosting this event it's between South Pointe Hospital and Stephanie Tubbs Jones Health Center. We are also celebrating the 100th year anniversary of the Cleveland Clinic and 100 years since the discovery of insulin. And also, in addition to all of this, November happens to be National Diabetes Awareness Month. So what a great way to enter the month of November with this great webinar. November 14th happens to be World Diabetes Day. And if you happen to notice your educator or your endocrinologist is wearing a blue circle pin, that is the symbol for World Diabetes Day. My name is Sue Cody. I'm a registered nurse and a certified diabetes care and education specialist. I work at Stephanie Tubbs Jones Health Center. We are so very excited to co-host this event with South Pointe Hospital. And it's jam-packed with information for you today from all the experts here at the Cleveland Clinic. Before we begin, I would like to introduce Shannon Knapp, who is the manager of diabetes education at the Cleveland Clinic, with a special commemoration. Thank you, Shannon.
Thank you, Sue. We're wearing our masks for safety here because there are two of us, but I want to assure you that I am certainly smiling under this mask, and that is because I have with me Miss Lynn Timko. And Lynn, Sue mentioned that this diabetes fair has been going on for 20 years. That's our best estimate of it, but it's at least 20 years. And prior to this being virtual, it was in person at South Pointe. And Lynn is really the person that is responsible for all of that. She started the diabetes fair and she continued it, and she was the planner for it and organizer for it for at least the last 20 years. She retired just at the beginning of September after putting in a lot of work planning this year's fair. So she was lucky enough to retire in the beginning of September, and I can confirm that she is already enjoying her retirement. But we did want to commemorate all of the work that she has put into this diabetes fair over the years. And so I have this award for Lynn. Oh, and I will read it to you. It says it's the Distinguished Service Award presented to Lynn Timko, RN, CDCES, for her years of caring service to people with diabetes. Oh. So there you go, Lynn.
Oh my goodness. I am so touched. Oh my gosh. This is such an honor. Thank you. Thank you to our hospital and our health system, and mainly, thank you to our patients. All these years, I was blessed, very blessed, to be a nurse here at South Pointe Hospital. And I can't tell you what an honor this is. Thank you, Shannon and the team. Oh my gosh, I'm so surprised. And I'm smiling through my mask too. And I'm enjoying retirement, but I sure do miss y'all and all the patients and all our friends out there in the community. Thank you for this award. And I'm just blessed and honored to be here today. And thank you again. And thank you to Sue Cody for also that wonderful being friends all these years, and Shannon and all of our physicians and doctors. Thank you so much.
Thank you, Lynn. Thanks for coming back. And Sue, back to you.
Thank you, Shannon. That was a wonderful tribute, Lynn. Congratulations, and we miss you. I've had the pleasure and the honor to work with Lynn for many, many years. So before I introduce our first speaker, just a couple of housekeeping issues. First of all, participants, if you will automatically be logged into each session. But if you feel like you need a break and you want to, delete one or don't want to participate in one of the sessions, just go back to the website and you can log back in. There's an opportunity to ask questions in the Q&A box on your right-hand side of the screen. And be aware that there are going to be pop-ups during some of the presentations. So those will serve as reminders and links for some of the information that the speakers are referencing. There's going to be an evaluation at the end of this, and this is very important. We want you to fill out the evaluation. So we know if we did a good job, and we know what we want to do next year. Also, it's going to put you in a raffle, and the winners of the raffle will be notified by email after November 10th, which is next Wednesday. So please fill out the evaluation. That will also assist us getting you all this information. All these presentations are going to be uploaded to our website, so you'll have the link for that, and more to come on that after, in between the speakers. So our first speaker, our keynote speaker today is Dr. Lansang, and I'm going to tell you a little bit about her. She is currently the professor of medicine at the Cleveland Clinic, Lerner College of Medicine, Case Western Reserve University, director of endocrinology at Cleveland Clinic main campus, and director of the inpatient diabetes services in the Department of Endocrinology. The title of her presentation today is Defying Diabetes, Matching Management with Your Needs. Thank you so much, Dr. Lansang.
Thank you. Thank you, Sue. Thank you to Lynn. Whatever we do today pales in comparison with all of the things that you have done throughout the years and enabling us to contribute in a little way to what you have done. So thank you. So I hope that the listeners don't delete me. And I hope that we have a way to enhance your knowledge about diabetes and fill in the gaps that maybe you have brewing in your minds. So I am discussing ways to defy diabetes in the sense that we don't necessarily have a treatment for that yet. Having said that, there are patients who have lost weight and go into remission, but other than that, we are stuck with medications and also checking our blood sugars. So our lifestyle is also affected by such conditions. And I want to promote some other ways that maybe the two will merge, diabetes and how you live your life. So I want to go through what it is that we have to discuss with patients and think in the back of our minds when we are helping you and you're in front of us or on the phone or on virtual visit. And that would be, what are the goals that we have agreed upon? And what are the medications to help with diabetes, considering the other conditions that you have, or maybe complications of diabetes? And then for those who are on insulin, there are different ways of matching what you need to what formulations are out there so that it is not in the way, but rather assisting you in managing diabetes and carrying you through your day-to-day living. As a reminder, in the United States, about 1/10 of the people have diabetes, but 1 in 5 actually do not know that they have it. So this is still a staggering statistic. And for the people who do have diabetes, especially if the management is not at par with what we need, you have an earlier risk of death. And the chance of that is about 60% higher, if we compare the same age. And the cost of medications is twice as high as someone who does not have diabetes. Not only that, the chance of being admitted to the hospital is also about 1.5 to 2 times higher. So these are economic costs that we need to keep in mind. And as having diabetes, we are aware of the possible complications that you might have. We call some of them as microvascular complications because they affect small blood vessels, such as the one in the eyes or in the kidneys or in the nerves. But there are also macrovascular complications, large vessels, such as the heart and our brain. So stroke and heart attacks are also foremost in the complications that we'd like to avoid. So those are the reasons why we need to pay proper attention to management. So when you see Dr. in the office, right? It's not as if every single thing that we say is something that sticks in your mind. So it has to be an impactful and meaningful visit. And we have to pay attention to what is important to you so that we can go along those lines and help you with your health. We could cite the statistics, maybe, we could cite facts, but if it doesn't help you personally, it may not motivate us to move forward. So it is a conversation that you need with your physicians. So let's start with the hemoglobin A1C, and I hope that everyone does have an idea of what this is as well. But not everyone in the group might already have the knowledge, the advanced knowledge of diabetes. So I am starting with some basics. The hemoglobin A1C, or A1C for the shortcut, is a measure of your blood sugar or blood glucose for the past 3 months. It is obtained with just one blood test. In some of the clinics, such as ours, we can sometimes get it also through a finger prick. But that finger prick is not, what your sugar is at that point in time, but it tells us how many months, 3 months ago, how your average blood sugars have been day to day. And that is possible because glucose sticks to your red blood cells. And that is what we measure. And your red blood cells kind of stay in your circulation for 90 days or so. It is not the average of how many finger stick blood sugars you check on your meter, because sometimes people just check once a day. Some people check 10 times a day. It is your day-to-day, minute-by-minute blood sugar sticking into that red blood cell. So that is a very important parameter of glucose control. And it is important that you know what is your target, because everyone is different. Now, in general, when we talk about the population, the entire population, for most of it, it has been said by the American Diabetes Association, for most people, can be less than 7%. And in fact, in many people, it could be lower than that, as low as it could go, without any cause of low blood sugar or hypoglycemia. But not everyone needs to be at that level, because there are conditions that would make it inappropriate. When we step further into detail, you need to also know what your blood sugar targets are. And again, from the American Diabetes Association, most of you will have to target blood sugars that are 80 to 130 milligrams per deciliter. And after you eat, whether it's 30 minutes after or 2 minutes after, hopefully it's less than 180. But many people are able to achieve tighter goals than this, because maybe they're otherwise healthy, or their medications do not cause hypoglycemia. And many people cannot reach this stage, or maybe it is even not appropriate for them to have these goals, because they're a little bit on the frail side. They have other complications, and tight glucose control might make them go into problems, especially very low blood sugars. If we go into even more detail, there's a later talk on this, where we use a continuous glucose monitor, something that you put under the skin. Some of these monitors are something that you scan. Sometimes it's just on your skin for quite a while. And we download these readings. We can even see how many percentage of time of the day, or in 7 days, or in 14 days, that your blood sugar is in goal. And goal for most of these continuous glucose monitor readouts are 70 to 180, which again, we will have to match on your personal goal. So there are moving targets that are in the minds of the physicians and the advanced practice professionals when we discuss this with patients. So what is it that we look at apart from you in front of us, apart from the number, the blood sugar, apart from the A1C? We want to know how your general health is, how young you are, did you have a myocardial infarction or heart attack? Did you have a stroke before? Do you have limitations that would make it easy or difficult for you to use a meter, to use an insulin pen? What is the cost of your medications if insurance is not covering everything? And what are the side effects? Again, we'll talk about low blood sugars later on. If there were choices that were equal in its benefits, would a patient want one versus the other? Why? Because you're the ones who will be taking these medications. And if one form of medication is not something that's suitable for you in your lifestyle, but there was a similar option that was easier, would you be actually taking the medication? If you won't, then it also won't bring your A1C down. And then the social support, especially those who need insulin, who are the ones who are helping you. And if we decide that really insulin is the best for you at the moment, how can we deliver it to you so that it's easy or easier? There are many organs that are related to diabetes. Traditionally, we thought that it was the pancreas in the top center over there, because the pancreas is the one that produces insulin. And if we don't produce insulin, we get diabetes. But we know, going clockwise, that the brain is also related to this for how we feel, if we're full or not. The muscles for your exercise take up sugar. Going clockwise again, the fat cells, those yellow droplets, indicate how much insulin resistance we have, or are we able to use insulin that we produce or insulin that we inject. The kidneys also put out sugar through the urine. The liver controls how much sugar we give out. Also, that's why sometimes you wake up in the morning and the blood sugars are already high and you hadn't eaten since dinner. It's because of the liver. And then the gut, the stomach, and the intestine also help in the absorption of nutrients and glucose. So there are many classes of medications that affect these organs and how they contribute to diabetes control. In the past, again, because we only thought of the pancreas and maybe the liver, there were just two medications, what we call sulfonylureas, such as glipizide, glimepiride, and then the liver, which is metformin. And then after the 1990s, there was just a plethora of medications that came about, and has been found out again lately that the gut is very important. And that's why we have what we call GLP-1 receptor agonists, such as the dulaglutide, semaglutide, albiglutide, exenatide, or so. And then we also have medications that make you urinate sugar, what we call the gliflozins. So all of these are combined, and it is not uncommon that you might need more than one of these medications. Insulin, of course, is the staple for those who are not producing enough insulin on your own. And then we talk about, okay, a patient is in front of me, I already interviewed him or her, and what are we wanting to do? Well, weight is an important component of diabetes. And if that's not something we're helping you lose, then we will be up for an uphill battle. So medications that help persons lose weight fall into several categories. We're again talking about the GLP-1 receptor agonists. They are injectionables, but that might be a palatable trade-off for someone who wants to lose weight. Metformin is, again, modest in its weight loss ability, but it is an inexpensive medication and still the number one medication for patients with type 2 diabetes. What we call SGLT2 inhibitors, or the ones that make us urinate sugar, also affect weight. And the others that I've listed are kind of less common, but also used. Now, for people who have heart disease, right? Nowadays, there are diabetes medications who it doesn't just help with your blood sugar, but they've also been found in studies or trials that they have heart benefits, whether it's for prevention of heart attack or if someone who has heart failure. These are the kinds of medications that we look to when we are faced with someone with these risk factors for having a heart attack or heart failure. Again, the glutides or the exenatide or the gliflozins. So know that there are options out there depending on your condition. Now we also have medications that help with the kidney function, or at least help retard the progression of kidney disorder. These are what we call the gliflozins. And again, their action is to make you urinate out sugar, and they may also help with some weight loss. Now, of course, cost is an important issue for everyone. Insurance is not perfect. Insurance keeps on asking us to change what we take because they have changed what they cover. And the good old medications that are sometimes still affordable, even for some people, if they need to pay out of pocket, would be metformin and sulfonylureas. There's the first two classes of medications other than insulin that I alluded to a while ago. Now, there are medications that when we talk about possible side effects, this class of drugs may have fewer side effects than most. These are the gliptins like sitagliptin, linagliptin, and their known side effects might be some nasal stuffiness, or headaches. Of course, we can talk about rare side effects with all of the medications, but this class of drugs seem to have a good side effect profile. If we're talking about the sulfonylureas, glipizide, glimepiride, of course, weight gain and low blood sugars and an issue. Metformin might cause loose stools or stomach upset or diarrhea. Some of the medications that are injectable might cause some nausea, rarely vomiting, or pancreatitis in rare cases. In medications that make you urinate out sugar, the gliflozins, it might cause low blood pressure, might actually be helpful for some people. Rare cases of skin issues. Again, this is something that will be discussed with you and your prescriber, because then there's so much data to go through, but we're going after what will help you and what are the effects that we're trying to avoid. One other aspect that we think of then is it going to be effective? We talked about your A1C and your blood glucose control. When we see you in front of us and you have blurred vision, you're losing weight unexpectedly, you're having breathing problems already, you're urinating a lot, you're thirsty a lot. Well, that is a sign that even at that state, even if you have type 2 diabetes, your body is breaking down and insulin is going to be most effective at that time. If your A1C is very high, insulin is the one that would make it most effective to go down. Um, it can be used regardless of what your kidney or liver status is. We just adjust the doses. And that is also what we use in the hospital when your food intake is also fluctuating. So it's a very useful tool. And I know it is an injection most of the time, but it really does the job. If we are talking about, well, a doctor said I didn't really have that high of an A1C for my goal, well, this is the list of medications going down in terms of efficacy for A1C lowering. Again, insulin on the top, and then medications at the bottom may not lower your A1C a full 1% or so. So if you're starting out with an A1C of 13, then we know that insulin is probably going to be the best for you at that moment. So the timing of this South Point Fair is very, very conducive to learning about diabetes, and in particular, insulin is the 100-year discovery of insulin, and it has done wonders for many patients. Of course, especially patients with type 1 diabetes, but also patients with type 2 diabetes. This is just a mimicry of what our body does when we do not have diabetes. I do not have diabetes yet, but everyone in my family does. So I know I'm going to get it. That's why I'm in this field. The pink line in the bottom is the insulin that I produce when I'm not eating. Let's say I'm fasting the whole day. That's what it does. And the spikes are when I eat. I produce the same insulin, but in a spiking manner. And that's what we want to replicate. As you see, though, it's going to be 4 shots a day if you need insulin. 1 shot in the pink and 3 shots in the yellow. But this is what your doctors mean by basal bolus insulin. And we talk about basal insulin, the one that you need even if you're not eating. There are several kinds. And I always draw whatever we decide on for my patient, what it does. Is it a little bit flat? One of it, the NPH insulin, still cost effective, has a little bit of a hump, but this is what we're talking about when we say that you still need insulin even if you're not eating. And then when you do eat, that little spike that I'm talking about, there are many kinds of insulin as well. It ranges from the regular insulin at the far right in gray, which lasts a little bit longer. And then we have the ultra rapid insulin, which you don't have to wait 10 or 15 minutes. You just take it just before you eat. And again, science has come a long way in developing these. When we talk about glucose control, again, there's a talk later on continuous glucose monitor. We also know that if we just check just the hemoglobin A1C, we don't know if you're the one who blood sugars are going up and down, but just minimally, or you have an A1C that's 7 because you go too high to 300s and you go too low to 40s, and we do not want that as well. And so we try to match what insulin is needed for you to minimize those. Now, many of our patients are already on the insulin pens, but once in a while, we still get patients who are on the vial and syringe. Some is for economy because of insurance coverage, but some patients are not aware that they can be switched to a pen and needle and still may be covered by their insurance for it. And then what is your schedule? What are we trying to do? I already showed you what someone without diabetes, what happens to their body, and we will try to mimic that. It is flexible in that if you do not want to eat lunch, then you do not have to take your mealtime shot at lunch. And then if you have a delayed dinner, then you take it later. So that is the beauty of that 4-shot basal bolus insulin a day. And then there are other combinations with NPH insulin, or what we call a pre-mixed insulin, where in 1 shot you have 2 different kinds of insulin. One is this NPH insulin that lasts 12 hours, that still also has a hump, and one is a mealtime insulin. So when we look at the 4 shots a day and its flexibility, again, if you don't want lunch, skip that shot at lunch. If we have NPH, it still might be 3 shots a day. But if you have pre-mixed insulin, 2 kinds of insulin together, you might go down to 2 shots, but you cannot skip a meal. This is an insulin that's designed that you cannot skip a meal because otherwise you'll have a low blood sugar. So all of those are considerations. There are patients who want some flexibility and really like the ability to not have to bring around their insulin pens, and we have the insulin pump. It is not something that you can just take on lightly. There's so many things that go into the ability and the discussion and the agreement between your endocrinologist and the patient to go on an insulin pump. There's a lot of technical issues that you also have to know. There's some calculations that you need to know, and what is your backup if the pump malfunctions. There are insulin pumps now that adapt to what you need hour by hour, maybe even every 10 minutes or so, in terms of what you call your basal insulin. So instead of a shot of basal insulin, right, where when you take it, it's already fixed, This one, again, adapts to your needs very closely. There are other ways to deliver insulin that's not a pump. You can have what we call a smart pen, where it can help you calculate the dose that you need. There's an insulin delivery device that's just every 24 hours that you change. There's one that's an inhaled insulin. So there are several choices. Glucose monitoring, again, there are different ways to test the blood sugar level, or again, through the skin. Um, and all of these have to partner up with what your goal is. Of course, insulin then will have the side effect of low blood sugar, and that is something that has to be discussed with you and your prescriber, because you need to know how to prevent getting a low blood sugar, how to recognize the symptoms, and how to treat that. So I guess the bottom line is that now is an exciting era in diabetes, that we are not just limited to to three medications. There are several, and they can be in combination if you truly need insulin as well. It doesn't exclude the fact that you cannot be on insulin when, let's say, you're on pills. And then some of you do not need insulin at all. And what does that mean for your lifestyle? It cannot be, though, just the physician saying, or the nurse practitioner, or the physician assistant saying what you should be on, because again, if it doesn't suit you, the side effect profile, or what your medical conditions are, bearing in mind they've already thought about it, but at least for you to also digest the information, because you are the important part of this equation. Remember as well that there are many threats to your having the medication and the supplies that we just spoke about, right? COVID-19 has caused issues with supply chains, or so. Your insurance keeps on changing what you are covered for. We have to do prior authorizations, and it's not just you alone that day. So we thank you in advance for your patience, but knowing that even if we agreed on a plan, please recognize that it may not happen right away, because there are things beyond you and me that we don't know until you get to your pharmacy to get that medication. Many times we are also just on virtual visits. There are patients who I have not physically met in clinic, and I think we still need that in-person visit to really establish a connection. We do what we can by virtuals, but we are not able to do a great physical exam. We do not see the body language. So we have to communicate better with that limitation in front of us. I hope that with this, though, it has stimulated you to think that when we do come up with a prescription plan, it has you in mind. But it doesn't mean that you cannot ask questions, and it doesn't mean that we cannot form a partnership with your decision making, especially since it is you who's going to carry this out, and we are here to support you achieving your goal. If you are someone who needs insulin, whether you have type 1 diabetes, where it is really indeed a requirement, or patients with type 2 diabetes, because at the moment, for your situation, for your A1C reading, for your complications that we're trying to prevent, because your blood sugars are still high, once a physician says, and a nurse practitioner or physician assistant says that, okay, at this moment you do need insulin, it is not something that we think of lightly. But could there be other medications that could do the job? Again, I went through all the kinds of thinkings that we go through behind this, and it's a conversation that we really need to have. And a partnership between providers and the patients, I think, will help this go smoothly. It cannot be one way, but we do need feedback if some of the plans that we have laid out are not in keeping with what you are thinking of for your health. So, on behalf of the Cleveland Clinic main campus endocrinologist, where I am in our enterprise-wide endocrinology team, I thank you again. Thank you for the organizers for having us here, and thank you to you because I hope you're listening. Can't see you, but I hope to hear from you in the question and answer portion. So thank you to everyone.
Thank you, Dr. Lansing. That was wonderful, full of great information. There are some questions in the Q&A, so let me field these questions for you. First of all, the first one comes from Deborah. What does it mean to have pre-diabetes?
So that's a great question. Pre-diabetes, just by numbers alone, it is when your fasting glucose, let's say, is 101 to 125, or if you have an A1C, that's 5.7 to 6.4%. Knowing that depending on what has caused the pre-diabetes, some people have, let's say, a history of gestational diabetes, or some people it's their weight issue, that about 30% of patients with pre-diabetes, the number changes with studies, right? But a good portion would progress to diabetes. When that's going to happen, we actually cannot define yet. There's some calculations based off on weight, other conditions that you have, but if you already know that there are lifestyle changes that you can accomplish, then you are well on your way to trying to prevent you from going into diabetes. And I think that is the more important thing rather than the number, is the prevention of your going headway into full-blown diabetes, because now you just have the premonition, you have the sign, you're given a warning, and it is really best to try and prevent rather than going into diabetes and trying to backpedal.
Thank you. I think I'm always talking to patients about windows of opportunity, and pre-diabetes is the window of opportunity.
Yes,
Yeah.
yes, for sure.
Next question. I think I can understand this question. It says if you're not taking insulin but are taking, I think it's metformin or medication, should you still be using a monitor to check your sugars?
That's a good question. So in trials, it has not been shown that checking blood sugar alone, right, has helped people necessarily to get to goal. It's more of what do you do with that number. Having said that, there are classes of medications that cause hypoglycemia, low blood sugar, notably the sulfonylureas, such as glipizide, glimepiride. They make your pancreas produce insulin, and so it is the next higher risk of causing low blood sugars. The other medications, such as the glinides, may also cause low blood sugar. This is nateglinide, repaglinide, or so. In rare cases, medication such as metformin, again, rarely might cause the low blood sugar, but that is not the concern in that point. The concern is what do you do with the number? And if it motivates you to know that, oh, you know what, after my 2 slices of pizza, my blood sugar went up to 230 and I'm just on a tablet or so, and then you repeat the experiment on having, let's say, a healthier meal, and the blood sugar just goes up to 165 after you eat, then you have done yourself a good job of getting to that first step of knowing your body. So there is a benefit. It's just a matter of how often and when do you want to do it.
Thank you. Next question is, what is the difference between type 1 and type 2?
That difference gets to be blurred and blurred each day, but let me take you to the very start, and maybe the most obvious difference. So patients with type 2 most of the time have what we call an autoimmune phenomenon, where substances in their body, I'm sorry, are attacking the pancreas, such that the pancreas is not able to produce any insulin at all. In the past, these are the people who are called to have insulin dependent diabetes or juvenile diabetes. Now, that has blurred because you can be 50 years young and also still have type 1 diabetes, right? So it is more of the degree of the lack of insulin that your body is producing. Therefore, patients with type 1 most of the time, again, really need insulin from the very beginning. Type 2 diabetes is you have insulin. Of course, when you were first diagnosed, you have insulin, but your body is not able to process it. Maybe you are not in the ideal weight, so that your fat cells, your adipose tissue, is barring your ability to use insulin. Your muscles are not able to process insulin. You actually increase your own production of insulin. You may have a higher insulin level, let's say, than the person next to you who does not have type 2 diabetes, but you cannot use it to process the glucose. And so most of these patients have obesity or have overweight conditions. Um, they still can manage without taking insulin injections, and can still be just managed on pills or non-insulin injections. But again, with time, the differences can sometimes change. Um, Type 2 patients, to start with, later on may stop producing enough insulin on their own, and they can also need injections to manage diabetes.
Thank you. Next question. Do you anticipate an insulin pill in the future?
Do I anticipate what?
An insulin pill,
Oh,
oral insulin.
so
Uh-huh.
actually, it is in the study. There's actually an Oralin, which is an oral insulin. I have not been following that already, because every single time there seems to be hope, and then then we are losing it. And the issue is that insulin as a peptide, meaning to say amino acid chains or substances, when they're ingested, are rapidly degraded by the enzymes. So, but there are, of course, again, hints uh, every now and then that we are moving forward. That is as much as I'm comfortable to say right now.
Okay. The next question, and I think hopefully this participant is going to stay on board with us for the whole day, is about the Freestyle Libre 14-day reader. They just want to know your opinion. I know we're going to talk a lot about this later on.
Yes. So a continuous glucose meter, whether something that we call intermittently scanned, which is the freestyle, meaning say for you to know your readings, you have to look at it, or something that is already, you don't have to scan, you just have to look. That's called Dexcom or so. They are helpful to our patients in changing their lifestyle habits. Whether you are covered by insurance or not, for that kind of depends on whether you are on insulin or not. Some people who have the means, who have type 2 diabetes and are not on insulin, they may even consider, they have actually obtained it without their insurance, so they pay out of pocket, and they have found out on their own experimentation, again as a reinforcement, that what they are doing on a day-to-day basis with their physical activity, with them avoiding certain kinds of food, that to them is powerful, that they actually could do it. And I see that that's the value in many of our patients.
Thank you. Can diabetes cause a trigger finger tendonitis? And if yes, why?
Right. So the tendons, even muscles, tendons, all our body, they are affected by sugar. So and the flexibility of some of our body parts is also affected by glucose sticking to those. Um, in terms of muscles, tendons themselves, I actually do not know the very basic mechanism of what happens apart from just it affecting the contractions of the muscles that control those. So maybe you want to talk to your ortho specifically, but that the more basic mechanism is that it does affect every single body part that we have.
Thank you. So the next question is from Frederick, and we got a lot of questions sent in before the presentation that kind of address this as well. Have the endocrinology and functional medicine departments ever spoke to come up with a plan to treat diabetes naturally? So there were a lot of questions about natural remedies and holistic, treatments, therapies.
Yeah. So I know that we had just finished, not me, but one in our group had just finished a study, or I actually do not know if they're in the gathering data phase still, on in functional medicine, not being part of that. I am not sure what actually was prescribed to them. So that would be something to watch out for once they are able to disclose what the information is. And I think for several reasons, the the way that functional medicine and endocrinology go about answering a question is a little bit different. It could be complementary, but time and circumstance sometimes doesn't allow a great exploration. So clinical trials, I think, are the best way to go rather than just anecdotal evidence. And if someone is willing to participate whenever you see that there's a need for volunteers, then that is how we want to proceed. So, and again, funding is a little bit difficult. I know this is not the answer you want, but I'm highlighting the reason why there is not such robust information out there, is that funding for such studies are difficult, and previous studies may not have shown what we wanted to see.
Okay, thank you. So this question, it says, how soon after you eat should you take the medicine? And I'm thinking that
Okay,
it depends on what kind of medicine
okay.
we're talking about, right?
Let's start with the obvious. Let's start with the obvious, which is usually timed with a meal, and that is usually your meal time insulin, depending on the particular formulation of your insulin. If it's, let's say, a regular insulin, we want to do it 15 to 30 minutes before you eat. If it's the logs, Lispro or Aspart or so, we want to take it maybe at least 15 minutes before you eat. If it's the super fast acting, then it's as you eat. Tablets, most of them we want there actually before you eat, such that maybe it's already starting to do what it's supposed to do by the time your body receives food. Now, sometimes the medication, if you take on an empty stomach, causes a little bit of nausea. So most of the time, we are okay that you take it with your food. We often don't say to take it after, because we kind of want your body already prepared. And it will be more prepared once the medication starts its action already.
Thank you. The next question is about nutrition, and to the person that asked the question, we are going to have a dietitian. You're going to be able to ask her questions.
Thank goodness.
Because it's pretty broad. Are there foods that are best for diabetics to eat to lose weight?
So there are no foods really that you ingest that its aim is to lose weight. So I'm going to reverse that, in that what are you wanting to avoid? If we talk about diabetes, the first thing, of course, that comes to mind is carbohydrate, right? In that, because it causes the blood sugar to go high. If you produce your insulin has to react to the carbohydrate. Our own insulin and the injected insulin actually adds to weight. So a side effect of insulin or medications that make you produce your own insulin is weight gain. So that's why we say if you can limit carbs, and of course, how many grams of carbs, what are the carbs, or so it will be a more detailed discussion. But let us not also forget that fats have more calories than carbohydrates or protein. So a gram of carbohydrate will have 4 calories, and then fat 9 calories. So it's double the calories, and calories count towards weight gain. So if you're beyond the question of, oh, my blood sugars are high, let me lower my carbs, it's now more focused on weight. Then it's your saturated fats, even healthy fats are fats. And those are the ones that you will need to reduce in your diet so that you have the biggest bang for your buck.
Okay, we have about 4 more minutes for questions. So this one is, I just got diagnosed, was prescribed metformin. It's giving me stomach issues. Is it because I'm doing intermittent fasting, 18 hours, 18-hour fast, 6-hour feast, or is it because metformin is not good for me?
Okay, so thank you, and I'm sorry you were just diagnosed, and I'm sure you're with the intermittent fasting, you're already doing something to help yourself. So it is a very common side effect of metformin to have a stomach upset. This is the one medication that I actually say you want to probably take it with a meal to avoid that side effect. You probably don't want to take it at the time that you're in the fast mode. And there are other formulations of without prescribing you a medication right now. Metformin comes in different formulations, and some of them are easier on the stomach than the others. If yours is the kind of formulation that can actually be broken in a tablet, meaning to say the regular form of metformin, some people I've said, you know what, break it in half, see how that does, and then build it up slowly up to the dose that your physician wants. There's an extended release form that has less side effects for most people. So there are kind of tricks to that. And of course, if it persists, then that means you're not reacting to it. You have the side effect, and that might not be the best medication for you. Again, it's a conversation that you'll need.
Thank you. The next question is actually, let's see. I think we completed all the questions sent in. Somebody sent a pre-question in. What do you think about gastric bypass surgery?
It is very effective in causing the diabetes to kind of go away. There are technical terms for diabetes going away, something like diabetes remission. Some people are putting in the word cure. But of all the kinds of what we call bariatric surgery, gastric bypass, otherwise called Roux-en-Y, is the one has the most sustained effects on diabetes because it also has the most sustained effects on keeping your weight down. Again, it is not something that your provider will discuss lightly, right? By the time that it is discussed, you probably have done your best with your weight, and I'm losing you for some reason. Okay, with your weight, it's not working. You may have complications already. You may have high blood pressure or so. Eh, It's not a light statement to be saying we should consider that. And so it's just a matter of knowing what you were already able to do and not able to achieve, knowing that weight regain, and with the weight regain, coming back of the diabetes is known to occur. And you need to go to a center of excellence to do that, because you need all the support that you need, including a psychologist, when you go through the evaluation.
Well, I'm sorry, we have to wrap it up. It's 12:25. I want to thank you, Dr. Lansing, so much
Thank
for that
you.
presentation, and thank you, audience, for your great questions.
Great questions. Thank you.
So we're going to, our next session will begin at 12:30, and don't forget, you'll automatically get logged back in. Thank you.